This section will address mostly surgical, procedural, and liver-directed therapy-based questions, and there'll be more opportunities for other questions in later segments. All right, let's get started. Dr. Datta, first question is to you. If the tumors have spread to the liver, can somebody still have surgery? And what's the good time to do the surgery? Up front at the time of diagnosis or when the tumors are progressing? And are there any differences between pancreatic metastatic NETs and the small bowel NETs?
Yeah, so there's several questions there. I think that in general, for us to offer surgery for tumors that have spread to the liver, it sometimes depends on whether the primary tumor is still intact. Mm-hmm. I think that's one of the considerations. If the primary tumor is still intact and there's liver metastasis, we will figure out some way, whether using treatments as a bridge or time as a selector, to get some biologic vetting of what that liver metastasis looks like. The patients who benefit from surgery in general are patients who have relatively indolent, meaning well-behaving biology, and those that we can perform complete, as I mentioned in my talk, surgical resection. So to understand the indolence of the biology, we need some way to vet that, whether it's some treatment, as I mentioned, with the neoadjuvant treatments that I talked about, remember, starting with treatments before we get to surgery, or sometimes staging the procedures, meaning starting with the primary tumor, seeing what the liver metastasis is going to do, particularly if the small bowel is the primary tumor of origin and patients can get obstructed, like I said, so we tend to operate on those patients. It's a tailored decision. There's no one-size-fits-all. Mm-hmm. And again, as I said, this is where a multidisciplinary team and being at a center that has all of the options, Dr. Thornton, myself, Dr. Chauhan, others, like Sylvester has, is paramount to your care, because no one should be making a unilateral decision for your care. And because we are expanding the armamentarium of systemic treatments and interventional options, it's possible that surgery can be paired with each of those. And it's that combination treatment that really is going to optimize your outcome. So shouldn't have any cowboys anymore, whisking you off to the operating room and just, taking out a bunch of different organs.
Well said. I completely concur with that. And the whole push from NANETS is towards multidisciplinary care in neuroendocrine cancer patients. There's no straightforward patient. All right. Dr. Thornton, next question is to you. Are there liver-directed therapies for innumerable mets in the liver? And how do you choose between liver-directed therapy versus systemic therapy? Sort of the same question I had for surgery versus systemic therapy.
So innumerable, generally speaking, and I did have this on a slide, but I ended up taking it out. Usually our cutoff for doing embolization or Y90, which is kind of our therapy for larger bulk burden, we usually cut it off around 70%. And that's just because when we do the treatment, we're also treating your organ, which is the liver. And we want to make sure that you have enough liver left to continue to live off of. And the liver is just the most amazing organ. It's my favorite organ because it regenerates, and it's really a beautiful thing. But 70% for most people who don't have cirrhosis or other problems with their liver is kind of the cutoff for where they really can't come back from. And so if it's more than 70% and then we treat it, we may tip patients over the edge. And so oftentimes, if you have seen an interventional radiologist and you're approaching that number, a lot of times it will be staged. So I often will do a stage, 1 or 2 segments of the liver. The liver has, 8-ish segments. And so we will stage them by treating a couple at a time, so it will take multiple treatments. Regarding sequencing with systemic therapies, as systemic therapies come out, I feel that the interventional radiology community has had to change their and pivot from prior regimens. Used to be that we would just anything in the liver, we would just treat. However, now with the advent of different systemic therapies, sometimes we'll lead with systemic therapies and then we'll just address the progressive disease. So if there's just one area that's progressing versus the rest of it is stable, and we'll use that test of time and the therapies to guide where we might treat most.
Great, fantastic. We are really short for time, but if your question is not answered, we will certainly address in the subsequent Q&As, okay? Dr. Datta, can you speak on carcinoid crisis during surgery and maybe also during the interventional procedures during liver-directed therapy?
Yeah, so carcinoid crisis is a situation where if you have a functional tumor, remember I mentioned the function, so it's producing hormones that can particularly serotonin-related hormones. And you have a significant disease burden. So that hormone is usually metabolized in the liver, and if you have a lot of liver disease, for example. So when we are manipulating these tumors in the operating room, sometimes it'll release hormones that can cause a carcinoid crisis. There was this old wives' tale, or should I say husband's tale, we'll keep it gender agnostic, that, having an anesthesiologist ready with this medication called octreotide, which is just basically the drip form of the stuff that you get in the intramuscular injection, the depot injections, the somatostatin, etc., was going to prevent that from happening. Actually, now newer data suggests that it's probably not that important, and that it's really surgical technique, and on a case-by-case basis, using those drugs will prevent a carcinoid crisis. I can count on one hand where I've actually seen carcinoid crisis even when operating on very advanced tumors. And so the body is remarkable from that perspective. And so I think the jury is out on whether or not octreotide helps. But we have to use multidisciplinary care again. We have to partner with our anesthesiologists. It's about managing the symptoms. It's managing the consequences of those effects. And usually we can get our patients through it very safely.
Wonderful. Thank you so much. Dr. Thornton, regarding histotripsy, I'm glad that you addressed the elephant in the room. What is our plans regarding histotripsy, and is there any data from the NETs world to support it?
So the data that we have right now is from multiple cancers, really just treating, does this therapy, can it cover the tumor? And so the trial had included multiple different cancer types, and it's kind of to the point of the earlier talk, more like a phase 1. So does it work? Does it cover the tumor? So now you have to take the very small amount of tumors in this group and then generalize it to those populations. We haven't looked at neuroendocrine cancer specifically and how it responds to histotripsy specifically. But in general, we don't even have a lot of data on any cancer type specifically. And so it's hard to say what the long term is. And sometimes what I will say, and maybe this is unpopular opinion, when we have really great therapies like ablation, and we know ablation will get the tumor, it's hard to suggest something that is a little bit more investigational. However, if there's a tumor that's very difficult to get to by surgery or by ablation, I think it's a great option because of the non-invasiveness and the low complication risk.
Perfect. And
Can I make one quick comment?
Please.
I get a lot of patients asking me about histotripsy. I will tell you, the technology is fantastic. The innovation is amazing, and it will be a part of the armamentarium, like I mentioned. But we are not in the business of treating lesions. We're in the business of treating the biology of the tumor, and we're in the business of treating patients. Okay? So we have to remember that, and we have to remember that these tumors exist in a patient, and that one technology may not be the best way to approach every single tumor. And so, we have to have a bigger picture of how these tumors are behaving, which is what both Dr. Thornton and I, as well as Dr. Chauhan, are talking to all of you about, the biologic process of vetting the biology of these tumors.
Perfect. There was a follow-up question regarding histotripsy, and that was, is this used as a scanning technique without doing the histotripsy at the time to destroy the tumor? I don't think so. It's not but Dr. Thornton, any comments on that?
Well, the question was, are we also scanning at the time?
Do doctor use histotrypsy as a scanning technique without actually ablating? So they probably mean like it's an ultrasound type of imaging. We have far superior scans and dotatate and CTs and MRIs. So we don't use histotrypsy as a mean to observe or monitor the tumor. But certainly, when somebody is undergoing histotrypsy, this tumor needs to be visible to the provider.
That's correct, yes.
And
That
so
is
that's
one of the
important.
main limitations, is sometimes it's not visible during the procedure. And so if it's not visible, it can't be ablated with histotrypsy specifically, because it's very specific to the imaging equipment. Whereas sometimes our other therapies, we can go based on the landmarks from your prior scans.
By the way, great questions, everybody. We have 10 more minutes. Dr. Datta, how long after Lutathera would I be eligible for surgery?
Yeah, it's a challenging question, and I think it depends on, again, what the burden of disease is, what the dose of Lutathera that was used, what the consequences of the function of the organ that you're talking about, the functional consequences on the organ. We have very, very selectively done sequential surgery in patients who have received Lutathera, just because the treatment options are improving so much and the efficacy of these treatments are so fantastic. And so I think the jury's still out in terms of every decision is a tailored decision based on extent of disease, the effect of the organ, and the biologic effect of the treatment that you have had previously, whether it's Lutathera or some other liver-directed therapy.
This is a great point, and I'd like to just add, in past, we didn't really had good data, especially there was a concern after the radiation. Would there be scarring? Will make surgery complicated? But Lutathera is a very different type of radiation as compared to external beam radiation. And there was recently a study from Italy where they gave PRRT as neoadjuvant in pancreatic NETs. That means to shrink the tumors, like Dr. Datta was mentioning, using chemotherapy. In this case, our Italian colleagues used PRRT to shrink the tumor, and then the patients went for surgery, and they reported pretty good outcomes. So it seems, based on that study, that there's no overt contraindication for surgery after PRRT. But these are early days. We still have to study them properly and see if there's any complication, worsening risks with surgeries after PRT. But so far, it seems okay.
Or if surgery is even needed in those situations.
Correct.
You could have disease control with the treatment itself, and so surgery is just doing a big, dangerous biopsy. And so the question is if surgery is even needed in those situations.
Wonderful. A very challenging question to Dr. Thornton. Can liver-directed therapy make tumors spread?
So the only modality, in my opinion, that could potentially cause tumor seeding would probably be an ablation. And it's not very common in neuroendocrine cancer. It's much more common in other types of cancers. But as we travel through the skin into the tumor, we burn, and then we do a cautery on the way out. So we make sure that any cancer cells that might be still on the tip of the needle, we cauterize and make sure that we don't travel or track them on their way out. However, that's a potential risk that we do that. In neuroendocrine cancer, it's a little bit less of a concern because we know this is already a metastatic lesion, but for some other types of cancers where this is the only lesion they have in their entire body and this is a curative therapy, that can be a concern. With other types of therapies like Y90 and bland embolization, we're not actually touching the tumor, so we don't have that risk. We are just parking a catheter in the blood vessel that supplies that tumor and giving the therapy that way. So I would say possibly in very incredibly rare situations with ablation, but not really known to be the case with the other types of therapies.
I agree. And it's important to understand, fundamentally, metastatic cancer, when it's already spread to liver or any other organ, it becomes a systemic disease. That means the cancer, even if we cannot see it in the scan, it's still there. I can do a sophisticated blood test and find the circulating cancer DNA. So once the cancer is metastatic, unfortunately, it's already spread. And theoretically, we're not going to make it worse by either cutting through it, etc., because it's already metastatic. So I kind of reassure the patients often regarding risk of spreading further with any procedure for that matter. All right, let's keep moving. Dr. Datta, this one's for you. Can long-term sandostatin LAR or lanreotide cause diabetes? And a follow-up question, the same participant. This patient had a hernia repair and has now a mesh in the abdominal wall. Can this interfere with future PET scans?
I'll defer the diabetes questions to, if we have any endocrinologists here, or maybe Aman, you can take that. But the incidence of diabetes from long-term sandostatin is still small. It also depends on existing endocrine function, whether you have any pre-existing disease. It also correlates with sort of body habitus and metabolic syndrome. So there are many factors that are involved in that. In general, a majority of the patients are not facing diabetic crises or anything like that, from what I can recall. But you can chime in there, Dr. Chauhan. In the terms of the second question, the mesh, what was it?
A hernia repair mesh, can it interfere with monitoring, especially with a PET scan?
Typically not. It depends on what mesh was used. Sometimes the really old meshes can actually be seen on the CT scan, and so those can be actually, they can interfere a little bit with the imaging. But the more modern meshes, the meshes that are what we call biologic meshes, which are supposed to be absorbed by your body, they don't typically interfere with any of the surveillance imaging.
And I'll just tag along to that as a radiologist. A PET scan usually shows activity or lighting up when there's increased metabolism. So that might be tumors, but it also might be inflammation. So if you have problems with your mesh or chronic inflammation or chronic problems with it, that may light up, but it might not be tumor. And so that might be the only case where there can be some confusion, but oftentimes there's enough of a history knowing that the mesh has been problematic that you use that to understand what you're seeing on the imaging.
Wonderful. Just a quick comment on the diabetes part. Theoretically, yes. Actually, it can cause high sugars, and Carmente, my partner, is here, and she knows to check HbA1c every few months to keep an eye on the sugars. But over diabetes, which is not well controlled, is very rare. I've had very few cases where we had to stop SSA for that reason, but that's a rarity, not a rule. And we will talk more on this topic in subsequent sessions because there is a lot of talk about Ozempic, GLP, and other issues, metabolic issues. We will wrap up this session with one final question. Dr. Thornton, this one is for you. What is the approximate number of tumors you can ablate in one session, and how many liver-directed therapy can a patient get?
Such a great question. And I think that as an interventionalist goes along in their career, they refine that answer a little bit more. And it's not very cookie cutter. It really does depend on the patient, how big the tumors are, what their liver function is, what prior treatments they've gotten, which is why the evaluation component is very important. But what I will say, just I usually don't do more than 4 in a session. 3 I comfortably do frequently, but 4 is kind of pushing it. Not to say that you can't attack more liver, but should somebody have any sort of bleeding or anything like that, we want to make sure that we kind of control the amount of punctures that we make in the liver. Unlike Dr. Datta here, most of the time, if something were to occur, we would have to go back in with embolization. I can't just open the patient back up because I'm not a surgeon. So for ablation, 4 tumors at a time, and again, for the embolization procedures, we do a couple segments at a time. But I really look at patients' liver function in and of itself to really determine that number.
Wonderful. With that, we would like to take a 5-minute stretch break, and big round of applause to our experts here. Great job with the morning session.